Okay, I think I'll just jump in and say this is NAMI Tri-Valley. We are very grateful and gracious about having Alameda County Behavioral Health and Indigo Project here with us tonight. Thank you for remembering us. We are forever appreciative of that. And so I'm not sure Stacey, are you the lead on this or who's the lead?
Well, I like to say we're a team on this.
Okay, so
I, I
who'd like to take it over here?
thank you so much. I will be talking a lot in the next few minutes, so I guess maybe that qualifies as like the person to hand it to. Um, um, Thank you. My name is Stacey Smith. I'm from the Indigo Project. I'm here tonight with my colleague Jamie Dorsey and also ACBHD's Access Division Director Charles Edwards. And Jamie, are you able to share the slides? Super. We wanted to come tonight to speak with you about something that's happening that will be happening over the next several months, the Access Integration Project. You can skip to the next slide. Thanks. Great. And what we wanted to do was introduce this project to you, share a little bit about the purpose of this project, the timeline for the project, and also as part of this Access Integration Project, ACBHD will be choosing a new name for the Access Division. So we wanted to share how you can provide that input. And then we will have time for some questions at the end. If you want to put questions, well, we're in a webinar format. So if you're able to put questions in the Q&A, that's fine. We'll get to them after the presentation. Otherwise, we'll just open it up when we're done. Two slides, please, Jamie. Great. The first thing I want to do is provide a little context for what's behind this project. California began a multi-year initiative, the Department of Healthcare Services, called California Advancing and Innovating Medi-Cal, which some of you have probably more commonly heard of as CalAIM. And the purpose of CalAIM is to improve the quality of health outcomes for the Medi-Cal population. It involves the delivery systems, programs, payment reform, and it's a pretty big initiative. And the overall goal, though, is to create a more coordinated, person-centered, and equitable health system. There are a lot of moving parts to CalAIM. It affects a lot of different areas, and there are some components that have to do with behavioral health. And those are also designed to support whole person integrated care. The Access Integration Project that we're going to talk about this evening is one of the projects that Alameda County is working on, one of the initiatives that the county is taking on as part of that CalAIM, that broader CalAIM goal. And so that's sort of the background context for what this project is. So what is this project? What does access integration mean? Next slide, please. Thank you. So this is really about the helpline. Right now, ACBHD has two separate helplines, one for mental health and one for substance use disorder. And each of those helplines, you can get information, screening, and referrals. The mental health helpline is staffed internally by the county's Acute Crisis Care and Evaluation for System-Wide Services, which we more commonly know as ACCESS. I do like trying to say all of those words, though. I feel like it's kind of a tongue twister. The SUD helpline, or Substance Use Disorder Helpline, is staffed right now by Centerpoint, which is a nonprofit county contractor. Through this project, by July 2026, there will be one system-wide point of access for mental health, substance use disorder, and co-occurring mental health and SUD needs for information screening and referrals. And in effect, the services that Centerpoint is offering the SUD helpline services that CenterPoint is currently offering are going to move under the umbrella of the Access Division. CenterPoint will continue to provide other services to the county, but the helpline services are moving over to Access. Next slide, please. Thank you. So we thought it might be helpful to just sort of give you a picture of sort of now and then future. So now for a client, if they have a need, whether that's for information or services, they first have to decide which helpline they're going to call. Do they call the mental health helpline or the SUD helpline? Once they choose a helpline, the pathways through those helplines are similar. They can get information for mental health or substance use disorder. They can be screened. They can be referred to providers. For the mental health helpline, though, all of that has to do with mental health. And for the SUD helpline, all of that has to do with substance use disorder. Part of the challenge is that if somebody has, for example, co-occurring disorders, someone may call the SUD helpline thinking that that is their highest priority of area of need. They may call the SUD helpline for screening and referral, but during the screening process, the screening may reveal that their mental health needs are actually a much higher priority in that moment. And at that time, the person screening that client will connect them to the mental health helpline, and then they begin the screening process again for mental health services. Next slide, please. Once this helpline is fully integrated in July 2026, if a client needs help, there's one number for them to call. There's just that single point of contact for mental health and SUD services, information, screening, and referral to mental health and or SUD providers. And so you can see the contrast between these two slides. We hope you can see is this new experience is a much more streamlined experience for the clients. Next slide, please. So while some things will change, some things will not change as part of this integration. What will not change is eligibility criteria for services. That will not be affected by this integrated helpline, the new helpline. Both helplines currently provide language interpretation and TTY communications for folks who are deaf and hard of hearing. That will continue. Those services will continue to be provided under the new integrated helpline. I know many of you know Alameda County is deeply committed to accessibility and to making sure services are available for everyone. Both of the helplines currently are 24-hour helplines. They will remain. This new helpline will remain 24 hours. After hours support will continue to be provided by crisis support services. And then through the helpline change, nothing is going to change about county contracted providers. The list of providers is not going to change or be affected at all by the changes that are occurring with this helpline integration. What will change is, again, there will be that single point of access. And now, because all of this will be happening through the Access Division or whatever we decide to rename it, or whatever actually county leadership decides to rename it, screenings will be done by licensed clinicians. In Access, they're called clinical review specialists, and they will be trained in both mental health and SUD screening and referral. The Access Division's name is going to change, and I'll talk more about that in just a moment. 2 slides, please, Jamie. Thank you. So what I want to do is give you an idea of the timeline for this project. We started work in November 2024, and right now we're in that second column. We're kind of in the thick of preparing for the transition. There's been a lot of analysis of processes and procedures between Access and CenterPoint. We've been looking at staffing and staffing needs. We've been looking at training and planning for training. Training actually launches this month. And we've been talking to folks like you, and we will continue to go out and speak with stakeholder groups, and try to make sure as many people as possible know this is coming. And then as we get closer to launch date and even after launch date, we will keep coming back and having these conversations. In January 2026, we're going to keep working on that transition, but we're also launching, the county is launching a public information campaign to get the word out to everybody about this number, about where to go to help for help. And also that new name is going to be announced in January. And then July 1st, we are on track to launch this integrated single point helpline. The Indigo Project team will be around to continue to provide support to the access unit and to continue these conversations with you, with providers, with pretty much everybody who has anything to do with the helpline. Next, two more. Great. One more. Thank you. So access is renaming, I mentioned. ACBHD leadership decided that this was actually a really good time to rename Access to reflect its new role, because it's a bigger role, it's a broader role. It really reflects that CalAIM goal of integrated services, streamlined services, and so the Indigo Project is hosting a survey right now. It's anonymous. It's extremely short. And it's available in multiple threshold languages. There's a link here on this slide. There's a QR code here. We will send the link out again for NAMI so that they can send it out to you. And you are welcome to contribute your ideas for the name as many times as you want. This survey is open through September 15th. After the survey closes, we are going to provide the ideas to ACBHD leadership, and they will choose that new name for Access. And again, that new name will roll out in January 2026. So this is pretty much the introductory information we wanted to provide to you. We wanted to let you know this was happening way in advance. We wanted to give you an idea of that timeline again. And we are still working through pieces of this process. And so while we may not be able to answer all of your questions, we would like to hear your questions, and we will be following up after these information sessions that we're having with an FAQ document. So all the questions that get asked will be reflected, and all of those answers as we have them will be available. Jamie, I think we could take down the slides. Jamie and Charles, before we actually take questions, does anybody have anything they want to add to what I just said?
No, thank you. It was very informative and right on point.
Thank you, Charles. Okay.
Okay, my turn.
Okay.
Believe me, even though it's slightly smaller than what we had hoped, as far as audience, it will go out. But my comment mainly is when this gets renamed, I am truly hoping that it does not become something you pronounce as access, because out here it's a nightmare to communicate between Access Community Health, AXIS, and ACCESS, and sometimes we have to use both in one sentence. So we it really is something that simple, but I'm really hoping that that goes away at the county side. So, although I don't have an idea yet of what it would be called. I also want to comment that there's so many of us that have, and I'm a family member, but so many of us have loved ones with co-occurring disorders. I'm really glad to see this combined like this. It's only natural, and I know behavioral health is truly the way to go anyway, and that it's something that is being redesigned to fit the needs of both sides. I am hoping that Alameda County does truly have ways to help people with substance use disorder as well as mental illness. And I definitely want to keep my ear to the ground of what all is going to be designed, but once that gets launched, and how it can help. Is Alameda County equipped? And maybe Dr. Tribble, I will need to ask you that in an hour or so, equipped to be able to serve folks that need that kind of care. So I'm just, I'm glad to see that they're both being stitched together as it should have been years ago. And and I hope this does help save lives and gives quality back in other people's lives. So those are my comments. And all, as always, if whatever we can do, we definitely will promote whatever is decided on numbers and acronyms and whatever. I just don't make it too long here. It fills up space here. Okay, enough said.
Dr. Tribble, did you want to say something before I continued, or?
I heard my name, and so I think I'll respond. Thank you for the call out. Yes, we'll be doing more than stitching that to capacity together, because we have, since I believe I personally drove out to the state, I want to say in 2014 or 15, when we became a managed care plan for substance use. So we've been doing it. We just wanted to do it very quickly. So what we ended up doing was having that outsourced to make sure we don't lose any momentum. So we have a whole cadre of providers, networks. In fact, 100% of the substance use services provided in Alameda County just happen to be contracted out. And they've been remarkably doing actually a great job, particularly in meeting the need and with very little barrier there. So we see it as operational and certainly long overdue, and I'm very pleased and thank to Indigo and Stacey and the team for doing the assessment, of course, to Director Edwards for leadership. We've been moving and pivoting in a lot of different ways. And I think, although he's humble, I want to acknowledge that some of the work, in addition to the integration that's happening, also means that staff will now work outside of the 4 brick and mortar walls or even virtual walls of phone access. So under his leadership, they've pivoted and have community-based access points. So the whole goal with this is obviously one of many opportunities for us to do things a little differently while keeping in mind what the state requires us to do as a plan, and all of the centralized features. We're trying to decentralize as much as we can without breaking any walls that they've established for us. So that's all I would add. So thank you for the call out. Happy to speak.
Thank you, Dr. Tribble.
You're
And
welcome.
I would love to be able to, if we would love to be able to come back as we get closer to launch to talk more about sort of some of the
Yes,
more
yeah.
details that we will have for you as well. So,
And we can better explain this to our folks in our community just after this presentation. I think that's going to help us much more, so that we can get people in the room, so to speak. Yeah.
yeah. I see there are 2 questions in the Q&A. One is, how will this interface with 988? And that is a good question. And that is something that we are not ready to answer yet, but we do look forward to answering as we get closer to launch. That is something that we are thinking about and talking about. And the other question here is that even though there is one contact number, your slide shows the client is served by either mental health or substance abuse, What about people who have dual diagnosis? Actually, one of the nice things about this helpline is that going to be easier, I think, for the screener to be able to screen for both mental health and substance use disorder needs. And so we're anticipating that those needs will be accounted for as that individual is referred to the appropriate provider, whether that is somebody who just needs mental health services, substance use services, or co-occurring disorders. Charles, did you want to say anything else about that? I'm putting you on the spot.
Yeah, thank you for that, Stacey. Yeah, that can be a complicated question, right? But and we'll figure that out more as we move forward, but it will likely be case by case, right? Some people might get referred in either or, some people might be seen by both, so providers in both systems and or either system, and it'll probably depend on the specific situation of that client, right? Clients might need to go inpatient or before they maybe see a mental health provider. They may need to go inpatient in the SUD system somewhere before they get connected to a mental health provider in an outpatient setting. So it's going to be kind of complicated depending on a client's unique presentation.
Thank you. That's the nuance that slide does not have. I appreciate that. Thank you. I don't see, oh, were there other questions? Let me see the Q&A.
There are 3 that have popped up, I see.
One is a question, one is a statement. One is an idea for a new name, some substance use and mental services. We are taking these down in addition to the survey responses. And then another question is, can people with employer insurance access ACBH services? That is a little beyond the scope of the Helpline integration. I don't know, Charles, you unmuted.
Oh, yeah, thanks. Still learning a little bit more about the SUD requirements and eligibility, but typically in the mental health side here in ACBHD, we're serving Medi-Cal recipients. That is the truth. And in some instances, people that have Medi-Medi as well in some instances. So, but definitely Medi-Cal. People with private insurance definitely are usually primarily served by their private insurer, if services are available. Yeah.
Right. Thank you. Any other questions?
I would only add one nuance. If it's a court mandated service, there may be some complexities there to which we would obviously offer and provide services. So in those ways, those are the alternatives. But as was mentioned, typically we will coordinate with whomever that private insurance provider is.
Thank you, Dr. Tribble. Well, if there are no other questions, we would like to end our presentation and make way for your main speaker. But we are happy to share the slides and certainly any additional information as it comes out. So we will definitely continue to keep you updated, and hopefully we'll be able to come back in 2026.
Well, thank you very much. We appreciate, we got a lot of applause over here, so great job. Thank you. Yeah, definitely, if we have any questions or anything, Stacey, are you the person, or who might we direct any future questions?
My email, Jamie's email, and my colleague Kevin Wu's email, who couldn't make it here this evening, we are all on the slides.
Okay.
And folks can email us with other questions. Again, we may not be able to answer all the questions, and we definitely will make sure that questions go into that FAQ document. So we are dedicated to capturing and answering those questions.
Great, thank you. So with that, we're doing a marathon here. We'll segue on over to our general meeting with our tonight's guest speaker, which is Dr. Karyn Tribble. And I'm just going to jump right in and just say Dr. Tribble is the director of Alameda County Behavioral Health, and I guess headquartered in Oakland, and but with different clinics in the different areas of Alameda County. We go back a ways, so it's so nice to see you back, and I'll just take the lead here and hand this over to you, Karyn.
Thank you. Thank you very much. I'm very pleased to be here. I've been here, I think, a few years at least, in the years that I could. So thank you for having me back. That means I didn't offend too much. So I'm very, very pleased to be here. So I do have a presentation as always, and as always, I'll also try to make it available. Shall I try to share my screen or?
Yes.
Okay, I will see if I am able to do that. I'm going to open this up and so can you see my slides? I don't know if you see my
Yes.
face.
Yes.
Okay. You cannot see your face as well as mine. You see just the slides. Is that correct?
They look good.
Okay, my computer's doing something very interesting. So as long as you don't see random faces, then I will proceed. So thank you again, everyone. I can't see everyone's face, so I will go through, and if there are questions, please feel free to interrupt or go through. Today's meeting, I hope to give your general meeting members some updates globally and very briefly with our department, general operations, and then some key changes that we see on the horizon as far as state and legislative implications. So I want to make sure that you all have that. So I'll start by going through the departmental budget. And again, I want to make sure you can see the slides and not my face. And not, I've got a little icon that you popped up. Good. Okay. I want to make sure the recording is well done. And then I'll show some current landscapes. And again, as I mentioned, some where we think we will be heading in the months and weeks to go. And some of which really dovetail to the work that you just heard about in terms of this access redesign. So I'll start with the budget update for your information. So firstly, the department continues to be structured, I believe when last I visited, in 4 key areas. It's a huge department. I'll speak about where we are. Our budget has grown, which means the need has grown in the county. The way that they calculate oftentimes the size is based on revenue. So we have grown tremendously, and it's humbling because again, that means the need continues to grow. So you'll see that we have 4 clear areas, strategic initiatives, objectives, making sure the changes are met. That is my responsibility. So it really is ultimately my accountability to my office and the role. But you'll see clinical operations, the Office of Medical Director, Health Equity, and Plan Administration. And essentially, what that work entails is really overseen by these leaders. I'm so pleased to see Charles here. He is part of clinical operations, and you see myself, and these are just our leaders. We're very transparent on who we are. Pleased to celebrate the arrival of our more recent leader, Dr. Anna Phillips, who is our director of the Substance Use Continuum of Care. She recently joined us from, happened to be from a CBO world, so we're thrilled to have her here. So all 4 of those areas essentially roll up to our executive team, the senior executive, which are the 4 to the left, myself, James Wagner, and the other leaders are there working on a variety of efforts. It is just a lot of work and there's accountability there. So we are providing that update to you transparently. So this continues to be the structure in terms of how the actual department is laid out. And as you can see, you have the various systems. We still organize them as clearly as we possibly can in our estimation. As Director Edwards mentioned, Division Director Edwards mentioned, we are a managed care plan in the sense that there are requirements that we have and eligibility requirements. So to the extent it's easy to understand, we organize them still by age. So adult and older adult, and these are just examples of the community programs that we have, which again, I presume you all are somewhat familiar with, as well as child and young adult system of care, substance use, and our forensic and diversion and reentry system of care. That one was fairly new. I believe at last I made a visit to you all, and that is because, again, the outcomes we were seeing and the recidivism and the intersections with jail and that work were just something that we thought needed to be significantly improved across the county. So it's under one system. So that means if a person, even by virtue of their mental health disorder, which we hope not, ends up in Santa Rita jail, there are more programs and services that connect with them outside of the jail. There are diversion programs that we've uplifted that are on the radar to continue to be developed. And there's some forensic and other programs, which I'll speak about in later systems. So, and of course, our substance use system of care, which goes across the age range. And there continues to be some overlap. If you notice, the older adults and adults start at 18 and the young adult starts at 20 to 24. And there's overlap again, just developmentally where a person falls and what's appropriate. Crisis services is across the continuum, very much so. And again, that actually is an integrated part of our system, so they can occur wherever the need is. And those are examples of those types of programs. We often get a lot of queries. It's interesting, folks will say, we like the CAT program. Why don't you all do the crisis assessment and transport team program like they do? We have to say that is actually us in the background. That was an innovative program we created, and now it's sustained across the counties, and we've expanded it to every area, most recently in Berkeley. We now include Berkeley as they no longer do a particular type of crisis services. So we're expanding there as well. One reminder that I like to tell people, we used to have a housing division. We no longer operate or oversee housing. We certainly fund it, but it now is managed through the broader agency, through the Office of Homeless and Housing, OHCC, Housing Services and Coordination. So I apologize. Housing and Homeless Services, I apologize. There's been an evolution. But that is through our broader agency. And so we will fund and we do those things, but the coordination is now outside of our department. So we rely heavily on them to help us with obviously the growing need in homelessness services for the county. So here is our budget, our agency budget. As I mentioned, we're still part of what is you can liken to as a university. We're one of 4 colleges. Obviously, of the $1.343 billion agency, we're large because we're at $831 million of that $1.3 billion agency. So it's mostly our department that is within the agency. But as you can see, we have our public health partners, our environmental health, as well as the Office of the Agency Director, which is essentially administration of and operates many different programs, including homeless services and some other programs. In terms of our budget, this is just a comparison. Now we're again at approximately $832 million. The number of county employees has risen only minor, very small degree. We went from about 799-ish. And as you know, a person can't be split in half, but we may have part-time positions and things like that. So we've only added about approximately 12 or so positions from last year. And as I mentioned before, 100% of substance use are still contracted out. We had attempted to do potentially some growth and having more county operated substance use programs that has not begun. Hasn't started yet, and instead we still rely on our providers, but about 79% this year of CBOs. So that does represent a pretty significant portion. 561 million, which is 64% of our overall budget, is contracted out. So we truly just hold, administer, manage, and ensure that it's out in the community again for most of the money that comes in. This is just the transparent. I won't spend time here, but people are often wanting to know where that $832 million, for example, is spent. And as you can see, most is in the service delivery, services and supports, or any kind of additional housing or other dollars may go there. We have transfers to the state, and there is a portion obviously with benefits and salaries. And we actually do support other positions outside of our department. It is not just our department. So we're really integral in county operations in general. This, I see some type of, I don't know what that is. I will try to fix that on another version. But this is just a breakdown, maybe in the flattening of PDF or what have you. But in any case, this is a breakdown of our budget. So I won't spend time there until I can get a better version for whatever reason, on this end. So this breaks down, again, this may be way more information, but I am going to spend a little time here because I did want to acknowledge in a later slide that I'll also be talking about federal impacts. And so as you can see, a majority of our funds are Medi-Cal. That is the primary amount. And Medi-Cal happens to be Medicaid. It is federal. And so all of the activities is how I'll say it, that's happening at the federal level. We're watching and we are looking at it. The good thing is that there is a litigation that the state has opted into. So there is a hold where we believe, or where we were first notified. If you see the bottom three, there's a federal grant, substance use block grant, which essentially is substance use services. And then we had another crisis and other types of federal grants. Very few. We do not rely heavily on our federal government to sustain the work. We rely mostly on state and the billing and the activities that happen here locally in the county. So they were to be used or taken back, but thankfully the moratorium, there is a cease and desist essentially where California's litigation precludes that from happening. But if you're following the news, you know that only included 5 states. California was one of them. So other states federally, they're impacted. Their impacts to federal resources will happen, unfortunately, without that protection, or may be subject to future attempts to litigate. And this is just a breakdown, as you can see, where most of our services lie. We often have questions about, well, what types of services are you offering? I.e., we've heard lots of advocacy, obviously, around, certainly we agree that most services should not occur. For example, in the jail, as you can see, that is not where most of our services occur. Only 7.7% of the services that we pay for are occurring within a locked jail setting. That could either be for children or youth. So that's coded as forensic. And so a preponderance of the funding and work that we do this fiscal year is on an outpatient basis, 24-hour services, which could be crisis, and it goes down the line just again for future reflection if you're ever interested to know what that looks like. So as you can see, that $24 million in terms of that we spend on housing, that again comes from our budget, but it is not overseen any longer by our budget. It is elsewhere, but then we do try to, we pay for services to our community and work in partnership. So I mentioned there's a lot happening, and I would imagine you all know that. So I wanted to take you through some of those things. The benefit, and again, I will most certainly make those corrections so you have a corrected version of the financing part. But these are links that work. And if you're interested to see and hear more, you can click on them at your leisure. But the things that are really important, if you see the first bullet, that's around accountability updates, and there's some system announcements. And what that essentially is really looking at our website is very public facing, and I've tried to work with our leaders and make it much more transparent. So if there are reports, if there were strategic plans, if there were significant changes, you can click on that at any time to see what the latest word on is. And we're continuing to try to improve that. We've also been doing a lot of work relative to settlement, the opioid settlement planning and opioid abatement. In our county alone, approximately $80 million has come to Alameda County, to our department over 18 years. So it's not $80 million every year. And that money must be spent to help abate the opioid use. And it comes from a federal class action lawsuit. Alameda County, we opted in. And so that is our portion based on metrics and need. And so we have been using those dollars to provide lots of services, many of which are in Tri-Valley. We use, for example, Three Valleys has been a really key partner in awarding many grants throughout the county. and they have been using those services as novel opportunities to get them out quickly. We've also Narcan distribution centers all across the county. And so if you click on that, you'll be able to see a report, for example, where our work is uplifted on a more recent update to the Board of Supervisors. We're also working to standardize and bring our electronic health record system into the, I don't know what century we're in, but 22nd century or 21st century, wherever we are. Alameda County is, again, very proud to be organic in the sense that we have different jurisdictions, very diverse, very different programs, some independent, some private, some for-profit, institutional, and yet the organicity of the county has been complex because we have yet to release a health platform very much integrated so that everyone can really communicate much better and have a true quality-based coordinated effort. Pleased to say we have been saving for the last decade. From when I was here the first time and came back, we've been accumulating dollars to devote. So we have saved about $33 million to pay for the EPIC electronic health records. For those that have Kaiser, this isn't a particular endorsement, but that's it, where you can look at your health record on your phone, schedule appointments, you can talk to your provider, the providers can make referrals. It is just a much more barrier-free way to provide support and care. Our broader agency, though, will be leading that effort. So we're pleased that we contributed the resources for that to happen, and we'll be partnering to make sure that we improve across the system and looking at ways to make sure behavioral health and substance use is also much more better coordinated. So there's an update there. Again, everything in blue with the underline has a link. Care Court, I believe that was something on the radar we successfully implemented in December, around December 1st of last year. That was when it was required to be implemented as court-ordered treatment, primarily for individuals with psychotic disorders or those that potentially could be at risk for homelessness. And so, ironically, Alameda County literally leads the effort, regardless of whether one feels court-ordered. It is semi-voluntary, meaning a person can't be held in contempt, for example, for not participating, but it is leveraged through the court and court-ordered treatment. And so we are actually leading in terms of the number of individuals that have gone through and been referred and supported through Care Court. We also have outpatient programs that were developed specifically for Care Court. So if a person is found by the courts to meet that criteria and the judge orders it, we will step in. They may order housing. Again, although we don't operate it here, but we'll work with our H&H partners to administer the housing. And if they don't, for whatever reason, we've also set up a pathway for people to still be connected if they've never been or if there are challenges. So we've had many visits already by the state of California. Senate offices literally have asked us to present, and have DHCS as well. And so we're very pleased that there is so much partnership between our courts, the district attorney, public defender, the healthcare providers. Behavioral health is just really a massive effort that we've done, and we're very, very proud of that. Indigo also helped us with that work and are now continuing to help us move forward. So very, very pleased at that. And again, people are getting served, which was the point. The African American Wellness Hub, again, speaks to the data we've been watching and reacting to. We also accumulated, we've been saving, I believe now 5 years, and we're able to purchase a property and have allocated approximately $20 million to the purchase and rebuilding and raising a property, given that, unfortunately, the metrics in Alameda County do not fare well for those that happen to be of African American or Black descent. There's higher incarceration rates and hospitalizations, and the quality of the healthcare we're finding, there's some disparate metrics that are unfortunate and disheartening, as well as there is more poverty in others and healthcare negative outcomes that we're seeing in the community. So that is to say, we're looking at this building to be a hub, whether it's behavioral health, it could be healthcare, a facility that actually has training and opportunities for people to provide culturally affirming and actually proven outcomes that help people to do far better than they have before. So we're very pleased at that. That process is under construction with our county partners. Again, the property has been purchased and they'll be raising it. And in the meantime, there are several programs that are working its way through the system to help support this effort. I encourage you, I'll speak a little bit about it, the strategic plan, to take a look at the full report, as well as an announcement about that. Those are links there. I'll speak a little bit about that. It's synthesized. And we are also very proud to say that we have publicly put forth an equity dashboard. So if anyone is interested to see who's being served, their age, their demographic, their race, their where they are in the county, where they live in the county, their sexual orientation, you can see that on our health equity dashboard. For those folks that would like to disclose, of course, it's not required. And if the number of individuals that fit a particular subset group are not too small, because we would want to keep clearly their confidentiality, we also enable people to take a look at that information. So again, you can look for yourselves, even in the Tri-Valley area, where people are located and who they are in terms of relative to the types of needs that we're seeing and demographically. This slide, I don't know if you all recall, and I hope you do remember that there is a lot happening. So we are trying to track, and it is, I wish I would say that this slide includes everything. It does not. These are just really major initiatives. You heard our Indigo partners mention CalAIM is there. Oh, I'm not sure why I went back. CalAIM is there, BHSA, which I'm going to briefly speak to, the care court that I referenced, opioid planning I mentioned, strategic plan, EHR. There are a lot of child and youth related changes that are occurring as well. So we're tracking on those. Peer certification, it continues to be something we uplift, and that we've been investing in many different providers to have it for free. Based on the allocations we give to the state. So local people in our county, we have gotten certified. So we're approaching 200 now. Very, very pleased at that. SB 43 is something, again, I think I mentioned to you all, and I want to highlight. It is now effective January 1st of 2026. The criteria for which a person is placed on a 5150 hold changes. So if there are questions later, I can speak to that, but essentially it expands grave disability, where a person can also be placed not only for a danger to self, danger to others, but also grave disability that might include substance use to the point that it's causing impairment, as well as if they're not taking care of themselves medically. So what that could look like is if a person is suffering and they're a homeless individual and they have a psychotic disorder and a festering wound, and they really need help, and they're denying treatment or just unable to care for themselves because of their behavioral health condition, whether it's drug or alcohol or even a psychological condition, they can be placed on a hold. So we have been working tirelessly for months, and there's lots of information. If people are interested, we can talk about that, but that is going to be a new law change, which is quite unusual since it hasn't been changed in the 60s. We've gotten lots of capital grants, about $170 million to Alameda County alone. We are incredibly proud about that. We made the decision, we made the decision to partner with our community providers because they have so many resources by virtue of properties across the county, and that's how much we have received. I'll show you later what those programs are like, but those are grants from the state to build. We also, through our budget, will have to fund those programs. So that's a requirement that we are very keen and understand the responsibility of that. So I've mentioned some of the forensic work, the health equity initiatives, including the dashboard. And as I said, the settlement implementation in this one is not necessarily the opioid settlement. This is, as you may know, the county is involved in litigation. And so that is key on our mind to make sure that we do right by the community and help our county to meet its obligations. This summarizes for people that are interested to say, what did she say? This gives you an idea of those initiatives and where they really fit. Some help to integrate the system to actually be more cohesive. Others are actually population focused. BHSA, which I'll talk about shortly, is one of those. And others involve community engagement, really making sure that the communities continue to weigh in on the work and also participate in the work. And so this is just helpful if you're interested to figure out, so how do you make sense of those initiatives? In terms of BHSA, I have been trying to give as many stakeholders as I possibly can updates on what that means. And so this is an example, again, for those that I would imagine this group is aware, we will be shifting from the Mental Health Services Act effective July 1st of 2026, this coming 2026, from that to the Behavioral Health Services Act. That is a hard, fast stop. And so, as you may also be following, the Board of Supervisors has signaled their interest in determining whether, as an essential critical service, some of those measure dollars would be able to support in programs or services that are impacted by these state changes. So we're still waiting for guidance further than the 80% to go to homelessness and 20% to other services. But I wanted to acknowledge the county absolutely is invested in looking at that. But in the meantime, we will be required to make these significant changes. And for those, again, just a reminder, this is the new breakdown, that no longer will we have different unique allocations, innovations. All the capital, thankfully, that we saved is important, as well as the money we allocated to electronic health records, because as of July 1st, that doesn't exist any longer. And so there are three types of allocations or types of spending you can use for, at least in Alameda, for our current fiscal year is about $200 million is our budget. So going forward, the allocation is going to be smaller, and I'll speak about that, but it will have to be 30% spent on housing related. And again, I just want to also make sure I'm very transparent to the public. In other counties, behavioral health has a greater foothold on what those housing services look at, but those are administered outside of us. So to some degree, well, to a huge degree, we're responsible for that. So we will have to build the infrastructure to ensure that 30% of the dollars actually do go for people with specialty mental illness or drug-related complexities. And that is also a new change. MHSA could not support an individual who was primarily suffering from a substance use. So that's a positive, at least, that now we can actually use the funding for that. That is going to be very helpful. 35% have to be for a very high intense wraparound program, which is called full service partnerships. And another 35%, you can think of it as everything else. So any other type of service that the county chooses to do based on community feedback, need assessments, that's what can be used for that. And the 10% now that we have to give to the state, as opposed to 5% previously, the state has indicated it will be using it for this. But it is very complex because for example, our prevention dollars locally were about 26 million. It looks like the state may have approximately 6 to 7 million to divide across California. So it is inevitable that there will be reduction in prevention services. There's no way about it. The math just will bear out that way. And again, I won't go into detail, but for those that are interested, this explains exactly then what that everything else bucket will have to include. And so even that is strictly guiding what our department will be able to fund. And so that's going to be very important. And again, based on the efforts or the delta between what may or may not be supported through other funding, including Measure W, we'll be having to make very hard decisions and move forward with discontinuing many of the programs that have been longstanding in the community. It's just in statute. This was what it will have to support. So I use this slide, excuse me, to further emphasize, I think appears to be, again, another, I don't know what happened in the translation of the saved document. I will promise to make sure there's another image here. But again, this is just the breakdown and what we anticipate. What is important to note, which I'll get to in a moment, is that we have been able to secure, as I've mentioned, a number of capital grants. And we're very pleased that this is an opportunity for us to build facilities where there were none. Highlighted is essentially that. We've also received different grants from the Department of State Hospitals. So we've received $8.25 million apart from the 170 that I mentioned to create diversion opportunities to help people, for example, if they're incompetent to stand trial because of their mental illness, so that they can be released from the jail or placed in a much more appropriate setting, for example, or so that they can essentially have a healthier place to restore and to be better off after being charged with felony offenses. So the person really can participate and not necessarily be another unfortunate outcome that they cannot help to participate in their own defense, for example. Bridge housing, again, we're very pleased that we have a total of $60 million that were awarded to our county. That essentially came to us and then has moved on to H&H. But again, we're very pleased. We've worked very, very hard to secure these dollars for the county and the community. So they will help us in terms of these grants. This is an overview of what those grants paid for, not for the housing side, that again is operated outside of our department, but for the behavioral health. We're looking at several residential treatment centers, some for at-risk youth. We're looking for crisis residential for justice-involved individuals, more crisis stabilization centers as well. We're looking at in Hayward, at Alameda, San Leandro, Livermore. There will be a sobering, detox, and residential facility, which is very much needed, particularly in that side of the county. And so although we didn't control where the state approved our awards, because we were very diligent in attempting to apply for many different grants across all parts of the county, these are those that were awarded, including work at St. Rose Hospital. We're seeing our aging community really need support, so we're looking to create a psychiatric inpatient unit for older adults, as well as medical-based detoxification. So there's just a lot of opportunity here. Again, we're very pleased, and you can see these examples of those. As I mentioned, we have a lot ahead of us, and I recognize that. So for those that may recall, we had engaged in strategic planning. Our strategic planning happened before the world turned sideways, if I can be honest about that, meaning legislative changes that requirements, new policies, new requirements that came up, care court, none of that existed. So we have been diligently trying to catch up with the requirements and to make sure that we honor what the community said by virtue of strategic planning. We are going to look at it from a true north perspective. I won't spend a lot of time. It's a lovely slide. This could be its own meeting, but essentially it just says, this is how we are focusing our efforts. At the top, our mission, vision, and values, really helping us to get to where we want to, focusing on wellness recovery. And the true north pillars are going to be, for example, how we're going to get to our strategic plan and implement it. So essentially, this is our framework that we'd like to make sure people see. This organizes those strategic initiatives that you saw on the previous slide. Please be on the lookout for more of these type of color-coded. There's just so much. We did a red light, green light, thinking that could help people, knowing obviously red is urgent, immediate, time sensitive. There may be something that's currently being worked on. Green is ongoing. It may or may not be as urgent, but it's certainly critical. And as you can see, you'll see yellow. That means that's something that may be in progress, being implemented, and we're closer to the green, or essentially having it in place. So as you can see, this helps us, and all of it is going to be governed by our strategic plan, which again, there are more links if you're looking at it. And so what does this mean in terms of the strategic plan? What did it say? So phase 1 was when we were distributing it to our community, and now we're in phase 2, a slow roll into phase 2 where we're reanalyzing the legislative impacts. And this is a highlight of really what it said. It told us that we need to focus on housing and collaborate and increase employment. And again, that's a nuance because we don't oversee it any longer, but we certainly have to build our own infrastructure to make sure that we can do right by these recommendations. Evaluate and improve the programs, because there was a lot of feedback from the community that said that we really needed to course correct in some ways, or to evaluate whether they're doing what they intended to do. Do more outreach, recruitment, make sure we're more equitable in the way that we deliver our services, and really improve the reentry and criminal justice work, as well as looking at how we can more evenly distribute, was a recommendation, funds in our department treating mental health and substance use, or actively looking at them. So again, even that integration project, though the state is requiring that we, oh, sorry about that, I moved somehow. Even though the state is requiring that we do that, it fits with our strategic plan, making sure that we're accounting for both needs of a person's experience, mental health and substance use, as well as co-design strategies, again, which is why we did so much, and we want to do more outward facing strategies to improve how we're structured in our department and in our county, and really bring in the community voice. So that's really high level. The strategic plan is much longer than what I described, but we thought it was helpful to help you understand in the coming months, we hope to actually have an implementation report. In that report, obviously informed by our pillars, and as you can see, access, quality, investment in excellence, and financial sustainability are those pillars. We will try to collapse many of those programs, the strategies, into the pillars of our department to make sure that as we're moving forward, if we're doing something that is a hard left, if it is not aligned with where we need to go, because dollars will not grow, they will be shorter in some ways, that we're really attending to what the community and our requirements say that we had to do. So this is a sample of what you may see in the coming months or years in terms of how that's organized. And at the end of the day, we hope to have a roadmap and an actual plan for specific strategies that are informed by the work that we're doing. And we will hope to provide that and roll that out to you all. Finally, and I know I've said so much, and please feel free, Marcia, to interrupt me if it's too much information. I know it's a lot. Hopefully it's helpful. These are some of the impacts as we see it to what's happening at the federal government. Why you'll see this slide particularly focus on synthesizing, it's important to note that that has been the voice we have heard mostly around the community. There's a lot happening. What does this mean? How does this impact us? What's going on? So specifically, if you think about those actions that happen, as I mentioned before, there is temporarily an injunction that is legally going to inhibit some of the cuts to Medicaid. However, there are others. For example, California has, based on some of those changes in terms of how it's reimbursed, as you know, again, regardless of what your political persuasion is, those who are undocumented, the California has changed it so that now if you are 19 years old and under, it will provide support. If you are 20 years and over, it will not, if you're undocumented in terms of Medicaid access. That's a huge number of individuals. And in this county, we do have individuals who are undocumented or aren't able to validate their documentation, I'll say. So we presume, particularly in our mild to moderate partners, our healthcare providers, they will have a huge impact and their services may be disrupted. People may not be able to access care. It means for us, because there is litigation, we may need to slow down expansion. We have an expectation that, for example, our providers can bill Medi-Cal, sustain programs, and continue to growth. We'll have to look at that. So depending on what happens over the next several months, we are slowing down what we normally would do in terms of growth so that we can be prepared. But that was a concrete example. The tax policy, oops, my presentation's jumping. The tax policy reductions, as I mentioned, the MHSA dollars are something that we are looking at. Currently, we're at $200 million for our budget, but because of those reductions and because of the reductions that did come from the current administration that was in previously, we're looking at about an $80 million to $100 million shortfall, because again, MHSA, which will be BHSA, is taxing those who make $1 million or more. That is where that revenue comes from. So if those individuals have capital gains or other ways by which to not have to pay into taxes, the downstream effect is that it means we'll have to monitor truly how much growth we'll have with BHSA revenue, because it's likely, we're already seeing the trends, it will reduce significantly because the millionaires obviously just will not have to pay into this tax based on other gains that they'll have. Again, immigration and enforcement is something that we're looking at. Access to services, we're watching how people, again, regardless of whether people believe that there should be people from other parts of our county, Alameda County is the richest in terms of cultural diversity, I would argue, in the Bay Area and potentially state. I know we are #1 in terms of the Afghan community, who may have come here through no fault of their own through immigration portals, but now may have challenges with accessing care. And so we're looking at more community-based, aligned with cultural navigation. For example, not necessarily brick and mortar with a huge sign, but actually if there are faith-based or other community-based organizations, because at the end of the day, our goal, we have to stay agnostic. It's irrelevant what the political landscape is. If there's a person in need, we are obligated, and it's the right thing to do to serve them. So that's what we see. The services will be impacted, and we're looking at how we can continue to meet the requirements and also service them. The Medicaid work requirements, this is something that, again, individuals who are on Medicaid and in California, Medi-Cal, will have to either show evidence or will have a limit to how long they can draw down Medicaid benefits. How we believe that will impact if an individual's, for example, we have a number of Medi-Cal beneficiaries in Alameda County. If their services are cut, our social services, we're tracking and working with them. Potentially, there may be impacts related to their housing. They may not be able to pay for housing any longer. Their benefits, if they're covered, they may be eligible for other types of housing vouchers and so forth. If those benefits are cut out, there is going to be a trickle-down effect. So we're looking at how people will be impacted in terms of that. And so vocational supports here for us means we have a whole vocational or employment division. We presume we will have to step up our support to individuals, particularly those who are severely mentally ill. So this is just an example of some of the impacts that we're looking at based on the federal changes and how it may impact our service delivery area. So putting it all together, again, these are the concrete strategies that we're looking at. Our outreach, our engagement, looking at how our programs directly tie into these new legislative impacts and changes or state required, how it actually will impact operations. We're looking at, are some of these dependent upon social services and other community supports? If so, will there be impact with a person accessing that? For example, CalAIM, for example, was predicated on the Medicaid expansion. The number of individuals who were placed on Medicaid in California was very, very high. Many of those individuals may not have as much access any longer, and certainly depending on what happens at the court level, we will watch to see what that looks like. As I mentioned before, productivity standards, meaning can providers actually bill Medi-Cal or other resources, and how can they draw down revenue? That's what we're going to look at in terms of how we do these programs, because if we expected a provider to do this work and they can't, then we have to be very realistic. We're really encouraging our community-based providers to use trainees and interns, any lesser degree lesser degreed or not as expensive type of revenue or excuse me, employment and other capacity be creative so that they can have the infrastructure. And by and large, really rely both on our peer-based services, the certification, and subcontracting. So leveraging as much as possible multiple groups maybe coming together where one has one skill set, one other has another. If there can be interagency collaboration or intra, we believe that will be very helpful as well. So as I round out, you know, what does this mean for us? It means we will be busy. We are really committed to the community, and it also means that the state is going to be holding us accountable. And when I say us, I mean not just behavioral health departments, but everyone is now responsible at the same time that all of this is happening. For example, to show, if you look at this image, this is a state slide, that they will be expecting that Alameda County, for example, not just our department, in general, shows improvement in the care experience. They show improvement to access to care, prevention and treatment of physical, medical conditions, quality of life, engagement in school and work. And I should say, these goals were established before some of those cuts or proposed cuts were made. So this is going to be a very complicated process. There is going to be a dashboard. There is a dashboard that will show individual counties' performance that you can literally look at. And then they'll also be looking at whether counties are able to reduce those areas. So I only say that it's a very ironic, paradoxical place we are, where there potentially may be cuts to services or changes in access, and we will be monitoring how this affects everyone. In terms of quality improvement, this will be very important. So again, if you're interested in hearing more, and there is also a link there that you can look at here from the state of California, they have accountability dashboards. And so if you're really interested in learning and seeing how the state is seeing some trends happening statewide, you can do that on your own as well. And the accountability update, again, is on our website and a link to our public document. And at the end of the day, the state is looking to integrate their review of counties. So no longer is it separate mental health, no longer is it separate substance use. They're really looking to combine and look at people in a holistic way, which is completely in line with the work we're doing and is something that we hope to really improve upon as we go forward. So as I close, there's a lot, and I know I said a lot. I hope it was helpful, but we want to make sure that people are really looking at the impact that potentially there's changes at the state, federal, their budgeting strategy. There's a lot more interagency collaboration we will need to rely on our partners, and that people really understand that now these programs will be less population-based in terms of global, but more population focused. So we'll be mapping our system, looking at care delivery, some of how the programs change, and as well as trying our best to engage the community as much as we possibly can. So at the end of the day, we'll obviously have to measure how things are happening and what the impact is. So we will be posting that as we continue to distribute information, and I hope you all do truly explore our website, because you'll see some of those things that have already been posted. And with that, I thank you. I thank you for the time, and I hope it was helpful in getting a sense of where we are.
I do have a question. Can you hear me? Uh-oh.
Yeah, yeah, I can hear you.
You can hear, okay. Dr. Tribble, can you hear me?
Yes,
Oh,
I can hear you.
Okay, all right, I wasn't sure. I just had a real quick question about, does Alameda County have a dual diagnosis program like Bonita House? Is Bonita House back providing that, or is there any other CBO that's providing?
Yes, we do have dual diagnosis programs, and I think it goes back to what Charles mentioned in his earlier presentation.
Mhm.
I would say a large number, nearly 60 to 70%, or even conservatively 60 of our clients have dual diagnosis. And so that's literally, it's part of all of our assessment portals, where whether you have a primary diagnosis that's not substance related, we expect, and our clinicians, when I say I mean our systems clinicians, will evaluate that from tobacco on up to cannabis use, medically or not, opioid, as well as how are they getting treated for their medical condition or mental health condition. So it happens consistently. Bonita House is one who actually strives on showing that, but what we're finding is so do our other partners. So many of them actually have, or organizations have, substance use counselors already integrated. They also, Telecare, for example, provides drug and alcohol as well, and support and groups and things like that. But our specialty, we really still do lift up the substance use providers to do the specialized work that they have been doing. For example, La Familia will be overseeing the Livermore site as well, you know, for the detox and such. And so they happen to be a mental health organization as well. So we're looking for people to become more adept. When I say people or organizations, to treat it just as a normal process, but at the same time, allowing there to be individual expertise. And we will probably continue with that, because we do know that there are some conditions or long-term care issues that it just makes sense. If you have, for example, experience with PTSD, you may not have experience with PTSD with a co-occurring substance use issue. So we want to still create those pathways. So it's a yes and.
Okay, thank you. So we had several questions on the chat. And I'm just going to read them for you, if that's okay with everyone. The first one is, oh, great presentation with lots of links on your slides. So that's a good start. Another, is there a way to get links and or on the slide deck? So you'll send us?
I will, yes. And I saw, as I said, some of the images looked at least jumbled on my end, or it could be my eyeballs are jumbled. I'm not wearing my glasses. I will make sure everything's working.
Okay,
Yes.
thank you. Next question is, how much advance notice of pending work requirements will there be for those on medical who are not currently working?
Great question. I'm not following the details specifically of the law, but we've heard different variations anywhere between, I almost don't want to quote something, I want to be inaccurate. So I have heard people talk about several months notice, because again, the way that we understand it is, in some ways, California is a little bit, I won't say protected, but we're now embroiled in the litigation process. So we may not have those changes occur. However, we have also seen, because of that fine nuance, that there's indication that as early as this next fiscal year coming up, people can be receiving notices. So I'm not sure how the federal government has written the letter of the law, but we presuming in the next several months, there's been some that says effective immediately, and I'm just not fluent enough to say what those are. So this year, for those that are receiving Medicaid, it's going to be the requirements themselves will be impacted absolutely in the next several months. So anywhere between 6 months to a year, depending on the particular type of benefit.
Thank you. One more question. Has the Livermore site for La Familia been determined yet?
Yes, it has been. It is the name of the road, I believe, is it Tesla Road? That pops up, but it's very far out there, and it's a very sprawling property. And so, yes, they're constructing. I didn't wear the right shoes, but I walked out there, and it's very large. And so depending upon, as the construction continues, it is purchased, it's being built, and we're working with La Familia and also District 1 as well, to make sure that we outreach to people once it's open.
Hey. Does anyone have any other questions? Oh, we got another one in chat. Okay. I'm glad to see the future expansion of the criteria for 5150 with regard to grave disability. Let's see, my daughter lives in a care facility, and if she's not caring for self medically, and becomes uncooperative with staff trying to assist her due to refusing meds and psychosis worsening as in the past, is there any chance she could be accepted for 5150 or not because she has care staff? Okay. Let's see.
That's a very good question. So technically, as of January 1st, and I won't, there'll be, we're designating many clinicians and we're providing that training. Technically, if she, wherever she is, if she, i.e., is refusing care, and this could even include not only a care facility in a hospital, emergency department or hospital location. So the law examples were initially describing medical needs that even could help medical physicians and others help people to place them on and then transport them to get their needs met or provide emergency support, psychiatric support, medications that could help them. So the short answer is yes, regardless of where they are. The law does not say that a person has to be on the outpatient side before they can technically have an appropriate 5150 assessment based on the expanded law. But again, every case would be different, and a clinician would actually have to lay eyes and evaluate the care to make sure that it's the appropriate determination.
Okay, I think that concludes, unless someone throws another question in at the last minute, I think that concludes tonight's general meeting. We're gonna ask you back again, and particularly with all the changes that are going on with the federal dollars,
Yes.
combining substance use disorder with mental illness and a Behavioral Health Services Act. We want to be a part of it. So certainly reach out to us and we'll try to reach out to you collectively. Tri-Valley is as equally important, and I know you know that. I really appreciate your time tonight. We'll be bringing you back. So
Thank you. I will. Thank you for having me. I take that as confirmation that I didn't talk you out of deciding to bring me back. It's just a lot happening. So thank you.
Really critical stuff. May not understand 100% of it, but with the slides, we'll crawl through it and take a look and
Absolutely. And feel free to email me or the office of the director at any time. Happy to provide what we can. So thank you all for having me, and thanks again.